Welcome back, class. We're going to talk for a few minutes now about cost, but before we jump into the cost side, I spent a lot of time, or I spent most of the time in the last segment talking about the provider side of the financial coin. If you think about the payer side of the financial coin, it works the same way. Payer side, they're concerned about marginal revenue, marginal cost. They're concerned about the marginal product of labor. And if then I'll just give you an example on that. That when I worked at Blue Cross Blue Shield in Buffalo, I managed the director of the payment integrity unit, and I was constantly looking at the marginal product of labor. I was looking at what was the change in output divided by the change in the number of FTEs I had. And also not only concerned about that, but trying to figure out that how much I could increase that output by bringing on an additional unit. And had some, medical economists working for me, and they were doing the calculations, and we had it figured out that each of our we had either clinicians that were reviewing medical records, or we had analysts that were analyzing data feeds from paid claims, and as we looked at it, and they were also identifying claims that when they were doing the analytical work, they were identifying claims that had paid inappropriately, and we were having to go out and bring the money back. We were having to recover those dollars. And so we had it figured out that, each clinician that we brought on, once they got up and running and trained, and we had probably a 6 or 8 month training process, that the return on that investment for bringing them on, they would bring in about, $2 to $2.5 million a year in dollars that had been paid incorrectly on the claim side of the house. And if I looked at my analysts, because the nurses are the ones doing the clinical reviews, were mostly focused on hospital claims, so bigger dollar claims. Most of my analysts were focused on medical provider claims, so a lot more claims, so a lot more volume, but lower dollar amounts or lower dollar thresholds. So, and they were bringing in about 1.5 million a year. So those two numbers were the numbers that I played around with when I was thinking about, what's going to be the change in quantity divided by the change in labor, how many, additional units I brought in. Also, we were looking at, the average product of labor. And I did it two ways. I did it, one, the number of claims everybody looked at and the number of claims everybody managed. And I split it out between clinicians and analysts, and also looked at it from a dollar value. So because the CEO and the CFO and the individual that I reported to were always asking about, what is the value proposition? What's the return on investment we're looking at? So, and it was to some extent, I don't want to say free reign, but based on the return on investment we had, we could have brought on some additional FTEs. It's just the talent pool was so shallow in Buffalo that it was really difficult. And this was pre-COVID. So weren't doing a lot of work from home, we didn't have a lot of remote employees. So everybody was pretty much in that Buffalo market, and the talent pool again was a little shallow. So we had trouble filling the number of potential slots that we had. But we could have if we'd had the talent pool. So it doesn't matter. Once you get out and go into if you decide to go into healthcare, you're going to, whether you're on the payer side or whether you're on the provider side, you're going to be looking at similar characteristics. You're going to have these similar microeconomic fundamentals that are going to drive the daily workload that you would do on either side of the house. So as I'm talking through this, I don't want you to think that it only fits on the provider side or it only fits on the payer side, because you have a lot of individuals, as I mentioned in the past, that cross over. They'll work on a provider side for a while, come work for the health plan side for a while. They may go into the government. They may go and work for CMS and do some work for Medicare and Medicaid. They might go work for DOD and do some work on the TRICARE, or go to the Veterans Administration and work on some VA work. So you have individuals in the healthcare market, at least in the labor side of the healthcare market, that individuals that are non-healthcare provider individuals that are floating back and forth on both sides of that financial coin. And the reason they can float back and forth on both sides of that financial coin is, doesn't matter which side of the coin you're on, it's the same microeconomic concepts that drive your ability to be extremely successful as you go forward. So we'll jump into cost, and again, cost, it doesn't matter whether you're talking about, as I mentioned before, whether you're on the demand side of the house or the supply side of the house. It's that marginal decision rule that's driving everything. Marginal benefit greater than marginal cost, you keep doing it. Marginal benefit less than marginal cost, you don't do it. Marginal benefit equal marginal cost, at that point you have maximized your net benefit, whether you're on the payer side, whether you're on the provider side. And again, the marginal decision rule is driving it all. It goes back to one of the three pillars. And when we talk about cost, again, providers are in the business to generate a profit. Look at the other side of the coin. You don't think health plans are in the business to generate profits? Look at United, look at Anthem, Aetna, Centene. They're all in there to generate profits. They've got shareholders. They've got equity shareholders. They have to generate a certain earnings per share. They have shareholders they have to answer to. Even if you're looking at a Blues plan that is a not-for-profit, they still want to make money. They've got to generate money to stay afloat. They've got to generate money to ensure that they are there in that particular environment for years to come. Not-for-profit to me is nothing more than a tax classification. So to me, the difference between for-profit and not-for-profit is a tax classification. So just remember that, whether you're on one side of the coin or the other, it's still being driven by profits. Everybody wants to make a profit. So accountants deal with explicit cost, and I touched on this a few minutes earlier, generated by a bill, an invoice. So you're thinking about, if you're on the provider side, you're thinking about salaries of everybody. You're thinking about the rent for the building. You're thinking about all of the, the machinery you've either purchased or you're renting. You're thinking about the furniture, the technology. Do you have electronic medical records? Are you still doing it by paper? How many computers do you have? That kind of thing. When calculating profits, economists evaluate explicit and implicit. So when you're talking about implicit cost, you're really talking about again, back to one of the pillars, one of the three pillars, you're actually talking about the opportunity cost of being a physician, of the building you have, of the equipment you have. What, you as a physician, if you start looking at, your bottom line, you say, well, I could go to work for XYZ medical group and I wouldn't have to worry about anything but just coming to work, seeing patients. I get paid a salary. I get to go on vacation. I get to go to conferences. I get to do all of this. And I don't have any of the hassle of managing an office. So there you're looking at an opportunity cost. What's the next best alternative for that individual's medical degree that they have worked hard to get? And so the economists are looking at that explicit and implicit cost when it comes to determining profits. And again, I think in the textbook Dewars uses, I think the individual was a GP, and he may have bought some radiology equipment. I think it was the example that the author was using. And the question that you have to answer is, are revenues available to cover your total healthcare cost? And that's the conundrum that hospitals, that the CEO of the hospital faces, that providers in a medical group are faced with, the ambulatory surgery center down the street, the individuals providing, prosthetics, orthotics, durable medical equipment. Everybody is faced with that at the end of the day. Will there be revenues available to cover total cost? I have a friend and we're going to digress a little, but I have a friend in San Diego that I was talking to the other day, and she made the comment that then she's Medicare eligible, and so she's on I can't remember who she's with. Maybe she's with United, either United or one of the Blues plans. I don't remember which, but made the comment that Scripps Hospital and Scripps Clinics in San Diego. So you got your two big medical systems. You've got Scripps and you've got Sharp. You've got Mercy Hospital that does some work, and you've got UCSD that also does some work, especially with the VA. But Scripps is one of your 800-pound gorillas when it comes to providers and systems in San Diego. And it appears that they've come to the conclusion that they're not going to see Medicare Advantage patients anymore. Can't make enough money on Medicare Advantage patients, so they're just going to stop seeing them. They're going to move on and try to have their business built on private health insurance. So that's what you're talking about when you're talking about revenues to cover total cost. And if you go back, to thinking about total cost, and it's not just microeconomics, it's accounting classes or it's some finance classes. The total cost curve is the sum of the total variable cost plus the total fixed cost. And your total fixed costs are, to me, pretty much, I call them a sunk cost, because they're there. It doesn't matter whether you're producing output or not, or whether you're getting paid for producing output, you're going to pay for those fixed costs because you've got, a lease you can't get out of. You've got probably contracts with suppliers for some of your disposable goods that you use in the office. You've got leases on maybe your computers. Maybe you've bought a license for that electronic medical record. So you've got a lot of fixed costs there. So a lot of providers will look at it and they'll say, well, I'm sunk on the fixed cost, but as long as I can cover my variable cost, I'm going to try to stay in business. So I think that's what a lot of providers will do. But at some point, if it gets to the point you can't cover those variable costs, you may want to close the door at that point. Doesn't mean you're going to go out of business, but maybe you just close the door until you can renegotiate with the health plans and get a better, a more positive financial rate in those health plan contracts. So, because remember, your revenue is based on prices and quantities. And, to increase that revenue, you've either got to up the price, which you're going to have to negotiate that with the health plan through the contract if you're a provider, or you're going to have to figure out how to generate more output. And generating more output, especially if you're a primary care doc, it's more office visits per hour. Doesn't matter how many hours in the office you work, be more efficient. If you're seeing 2 or 3 patients an hour, become more efficient. Maybe you bring in a PA or a nurse practitioner to help you and you see more patients. And so you bump that 2 or 3 an hour to 4 or 5 or 6 an hour. So that's when you're looking at revenue. And then it's the same thing on the cost side if you're a provider, because on your cost, it's prices and quantities. Your fixed costs are there. You're going to have to pay for those. And as you add more and more output impacts your variable cost. It doesn't impact your fixed cost, other than the fact that if you add more and more output, your average cost is going to go down over time, because the more output you add, the smaller and smaller impact that fixed cost has on your average cost. So your variable costs are the ones that are tied to the output that you generate, and your fixed costs are there, and you're going to have to pay for those, whether you're seeing patients or not. And same thing on a health plan side. You think about, the health plan, how do they generate revenue? They generate revenue by selling member contracts to employer groups, or selling or negotiating with Medicaid or TRICARE or Medicare Advantage to be a certified provider in a given geographical area. And then they get payments from Medicare, from Medicaid, from TRICARE, and they turn around and they negotiate rates with providers. And the way they make money, the way Health Plan makes money is, it's kind of like buy low, sell high. The flip side to it is, though, they're bringing, let's say they bring in $1,000 from Medicare, and as long as they can negotiate contracts and the total cost on a monthly basis for total average cost on a monthly basis for those Medicare Advantage patients is $800, let's say, they made $200 every month. So that's the way they're working. They're working on the payer side. That's one way of working your revenue. More contracts or more arrangements with either federal, state programs, more arrangements with the provider groups, and kind of squeezing on the provider side to keep your costs as low as possible. So again, making profits on both sides of that financial coin. And it's all a combination. It's all being driven by prices and quantities, revenues and cost. That's what drives, or at least makes the world go round, not only in healthcare, but in the business world in general. And if we look at the short run cost, it's WN, where N is the variable and K is fixed. So, and N is typically labor, and again, K is fixed, and it's your capital investment. And you've got a wage rate, W, on the labor cost, and you've got a R rate for like a rental rate on your capital. And it's the combination of those two where, variable costs respond to changes in output. So that combination between and again, capital is fixed, so that's your fixed cost, but it's your labor based on that wage rate that's going to drive those variable costs. Now, if you've been listening to, I can't remember, it was last week or the week before last, my days kind of run into each other after a while, but Kaiser Health Plan was in the middle of a negotiation issue, and they were striking. I don't know whether they ever really went on strike or not, but they threatened to go on strike. And what do you think happened to the variable cost for Kaiser if they had to negotiate a rate for their employees at a higher level? That W, so the function is WN, N is the labor factor, the quantity of labor, and W is the wage rate. What do you think happened to those variable costs if they had to negotiate a higher wage rate? Those variable costs are going to increase. That's going to mean that Kaiser is going to have to do a better job either managing other areas in their variable cost, or maybe other areas in their fixed cost, or they're going to have to generate some additional revenue or a higher level of revenue in order to maintain a certain level of profit. So you always are faced with, especially, and again, doesn't matter whether you're on the health plan side or the provider side, labor is a significant factor because it's the key variable cost that you can typically adjust quickly in the short run. So always remember that in the short run, you're looking at what are those labor costs. And Dewars also talks about the short run total cost curve. It's a relationship between cost and quantity produced. Again, increase quantity, you're going to increase your variable cost. See what else we've got. Again, talking about, short run total variable cost, or WN, short-term fixed cost, or RK, and those are going to be the drivers when it comes to that total cost curve. And the short-term variable cost, it's a function of the output level. It's a function of your input prices, Dewars talks about the quality of care, the patient case mix, and the quantity of fixed inputs. Well, if you think about, and I'll go back to the Scripps example. If I think about the patient case mix, if I'm a provider, even if I'm a provider in Nashville, if I'm seeing a high percentage of Medicare and Medicaid patients, I'm not going to be generating as much revenue as if I saw a higher percentage of private pay or employer-based individuals. Also, when you're looking at your case mix, a typically higher case mix on the Medicare side or the Medicaid side, or even if you're seeing some indigent care, the case mix typically on those types of populations generate significant more drain on your resources. It's just I think there's been multiple journal articles written about that, about the drain on the resources of certain case mix populations. So that's why Scripps in Southern California is probably getting out of the Medicare Advantage business. And just like I've tried to, I contacted 2 or 3 primary care doctors in the Atlanta area just to see that, trying to help friends get in, and they've decided they weren't going to take on any more Medicare Advantage. So Medicare Advantage is going to be, if you're a Medicare Advantage or Medicaid, it's going to become more and more difficult to find providers that are actually willing to accept those health plans. And then Dewars talks about long-run economies of scale implies that average costs fall as firms grow because of specialization in labor and capital. Repetition improves proficiency and efficiency and increased output at lower cost. And so that's what we're talking about, economies of scale. So if you're looking at economies of scale, that average cost curve, whether it's long run or short run, and typically economies of scale, you're in the long run. So you're looking at long run economies of scale. That long run average cost curve is coming down. It's coming down because you're becoming much more efficient. Coming down because you've got you've found a change in your production function. It's coming down because you're becoming more and more specialized. Again, my primary care doc, they've got the little tech that sees you, and then the PA comes in and sees you, and then finally the doctor comes in and sees you. They are specializing, and it's improving efficiency. So in the long run, what happens with most curves, or what's happened with most firms in the long run, is that economies of scale starts out at low output. It starts out coming down, long run average curves comes down, and then there's a range of output where it flattens out. So you've got constant returns to scale. And then at a certain level of output, that thing starts going back up again. And that's, when they talk about getting into diseconomies of scale. And in most firms, they allocate that diseconomies of scale to management issues. Managers cannot keep their arms around all of the units and make sure the units, because as they expand, as they get bigger and bigger, it's more and more difficult to manage a group of units to ensure the efficiencies there. If it's a small level of output, it's pretty easy. If it's a mom and pop type firm, they can manage, and that they're going to have those, economies of scale, and that's, at lower levels of output as they go forward. And then they're going to hit that area where it's the constant economies of scale. And you will see, and I have seen it in the past, not only in hospitals, but in provider offices, where they actually hit that diseconomies of scale because they have brought more and more people in, and there's just not enough tools, let's say tools, to go around so that they can take advantage of the efficiencies that they had early on in economies of scale, or even in the constant returns to scale. Dewars talks about diseconomies of scale result in bureaucratic and communication issues. And to some extent, that's true, because it goes back to the management process. How does a manager keep their arms around everything? How does a primary care doc or a group of primary care docs, even if they have an office manager, and most of them do, if they've got an office manager, can the office manager keep everything moving in the right direction and as efficiently as possible as that scale starts to increase over time? And one thing that when we talk about cost, you go back to, I don't know whether any of you have read it, but Adam Smith's Wealth of Nations. I think it was written in the 1775, 1776. The Scottish economist. Most people credit him with being maybe the first true economist. And in his Wealth of Nations, he talks about advantages of scale, and he talks about specialization. And so his Wealth of Nations, his article or his book that he wrote is, kind of the driver of this concept of economies of scale and, concept of specialization. And you're probably going to see more and more hospitals where they are becoming more and more specialized. Maybe I'm reading articles, I don't want to say constantly, but on a fairly frequent basis, where hospitals are deciding to become more and more specialized. And because of labor shortage, a lot of them are eliminating obstetrics, OBGYN, labor and delivery. They're not going to deliver babies anymore because of the risk associated with it, and they can't find the qualified individuals to fill those capacities. So rather than having hospitals having such a broad, kind of a broad scope, so you've got, and that's kind of the difference between scope and scale. Scope is kind of when you've got a broad scope and you're trying to be efficient across a multitude of service categories. And scale is when you function and you specialize on certain areas and become extremely efficient in those certain areas, because at that point you can increase profitability. And not only do you see this in the provider community, but you see it on the payer side. You have a lot of health plans that, especially a lot of little regional health plans that are do a really good job at managing a Medicaid population. AmeriGroup, that was purchased by Anthem a few years ago, their claim to fame was they focused on nothing but Medicaid, and they were really good at managing that Medicaid population. You have a lot of health plans that, especially some of your bigger health plans, that have gotten out of the Medicaid business altogether. They just, they've turned the Medicaid book of business over to some of the smaller regional plans that, again, in that low output, so regional plans with, 150, 200,000 Medicaid members, low output, but they've got it under control. They've got those economies of scale in that low range of output, and their long run average costs are really good shape, and they're making a lot of money on the Medicaid book of business. So you're starting to see health plans start to maybe start to shrink their scope in such a way so they're focusing so they can capture some of those economies of scale. And at this point, we're going to stop there for a few minutes. And when we come back, we're going to talk a few minutes about the nature of supply.